Hello, everyone. My name is Victoria Sigielski. I'm a member of the National APAMSA Alumni Board and former National Board member of APAMSA, and I'm very excited to welcome you all to National APAMSA's Radiology Bootcamp, which is our 7th and final bootcamp of this bootcamp series this year. Radiology is particularly important because it's a gateway to understanding the human body in ways that few other fields allow through multiple modalities, X-ray, CT, MRI, ultrasound, just to name a few. And radiology is the hub of the hospital, the bridge between specialties, whose interpretations shape and alter patient management. Therefore, our stellar panelists, Doctors Jennifer Huang, Dora Chen, and John Liu, have designed today's boot camp not just for upcoming radiology sub-Is and interns, but also for medical students of all levels, offering you practical approaches to common issues ranging from conditions from indications for imaging to pre-medication to basic interpretation. So I'll hand it over to Alan Chen, one of our wonderful alumni co-directors, to orient you to today's format.
Thanks, Victoria. Let me share my screen really quick. Okay, so welcome again to our Radiology Bootcamp, which is the last of our bootcamp series, hosted by fantastic alumni residents and attendings. As you can see, we've had a lot of different ones and they've been very successful. So if you enjoyed them this year, keep an eye out for them next year as well. We'll be repeating this series as we do every year. Just a few rules and reminders for today. If you have any questions during the series, just drop your questions in the chat, and one of the other attendings or residents will be able to answer them in the chat. And we also promote audience participation. So if you do have any burning questions that you want to ask, you can raise your hand and somebody can call on you. And with that, I'll let Dora start sharing her screen, and she'll take it away from here.
Hi, everyone. I'm Dora. I'm a PGY3 radiology resident. I'm originally from Mississippi. I went up to the Northeast to do most of my schooling, and I came back down to Tennessee to do my radiology residency. So today what I'm going to do is just a quick run through of some facts about radiology life, the reality of it, and then questions that you might have for radiology when you're on your sub-I or you're an intern, and then some questions that you might be asked when you're an intern on rounds about reading chest radiographs. So a few facts, radiologists work collaboratively. I'm not sure if that's a common known fact, but we talked with consulting physicians to clinically correlate and discuss next steps. We also work really closely as residents with attendings. We do readouts at the workstations, opportunities to do case conference and lectures. And we also work with co-residents and fellows. We get to sit in the same reading room and help each other and learn from each other. Another fun part is the chance to work with medical students. We get the unique opportunity to sit at workstations one-on-one as you all rotate through on your electives, and we get to participate in things like this where we give lectures. Another thing is that radiologists do see patients. I didn't realize this when I was a medical student, but not just our interventional radiologists, our diagnostic radiologists also have the opportunity to do a lot of various procedures and speak with patients, talk to them about their treatments. And uniquely, breast radiologists have the opportunity to not just work with breast surgeons, but also to work with our pathologists with pathology reports, get hands-on in the clinic by ultrasounding patients, doing biopsies, and sometimes even treatments like cryoablations. So if that's something that you're a little nervous about or wondering about, radiologists often have their own patients as well. The last thing is that a lot of people might say, oh, you must not like the sun if you're going into radiology. But the beautiful thing about the flexibility of radiology is you can arrange your schedule. So if you would like to work shift work doing 1 week on, 2 weeks off, or if you would like to work just your weekdays or you would like to work weekdays and weekends, you can arrange your life how you want it. Okay, so those were just a few facts. Let's get into the meat of it. So when you're a consulting provider, you actually play a very key role in the journey of every study. So when I'm in the reading room and I open a study, the first thing I do is I do a quick skim through, then I read the history that's been provided. I check the chart for more history, do a little bit of digging. I actually read the study looking for the things you've brought up to me in your history. I do my full search pattern since I'm responsible for everything in the image. Then I critical alert any findings, and I finish and I sign the report. The whole time this is going on, I'm getting calls, the techs are calling, the teams are calling, the patient's calling. And so there are actually 2 points in this process where you as the ordering provider, as the medical student, the sub-I can play a really important role in expediting the process. The first one is when you provide a history that has a lot of pertinent information that saves me time from digging through the charts. So I know exactly what I'm looking for. The second point is when you are judicious from the front end with the ordering. Do you need the whole area scanned or can it be a limited area? Do you need to order an inpatient? Is it truly stat or urgent? And will what I see on imaging actually change the way that we manage? This is just a history that came across my co-resident's desk that I thought it was kind of funny the other day. And they were right, there was a fracture. Okay, so on to the questions. You'll have this one a lot. You'll need a wet read. I pick up the phone and hear this all the time. So when you call, remember to tell me where you're calling from. What's your name, where you're calling from? That's important for me to kind of gauge what's going on and also for my documentation. And then try to be specific about what you need. Do you need an answer over the phone? Do you need me to actually type up or dictate a full report? And what kind of study are we looking at? If it's a chest radiograph, for example, I might say, sure, and it'll take me a few seconds to take a look. But if it's something more involved, like an MRI brain, I might say, hey, call me back or let me take down your name and get back to you when I can. This is an example of what it might look like when you get asked to call radiology on your sub-I or when you're an intern. So always introduce yourself, like I said, have your information ready so they can look it up. They'll ask for the MRN or the accession number, and then have a summary prepared about what you're asking for. For example, 72-year-old female with chest pain and shortness of breath, elevated white blood cell count. Do you see pneumonia? In the background, there might be some interruptions. Just bear with us. Okay, if you're wondering about if you should call, there's kind of a good general rule. So during the daytime, that's when we have our subspecialty reading rooms all full and a good time to ask non-urgent questions. But at nighttime, there might just be 1 or 2 residents for the whole hospital system. So before you call at night, just try to think about whether or not you would act upon the answer to that question overnight. Okay, when will my patient get their scan? I'm sure for a lot of you, the hospitals that you're at are seeing really high volumes and a lot of studies are getting done. This is a really good question. The operator might send you to the reading room and we probably won't know the answer to that question, but the techs would know, so you could ask to be connected to the techs. They're actually the ones that are scheduling the patients being brought down for imaging. Another question we get asked a lot is, can my patient get contrast? So you've probably noticed, even just on your clerkships, that every patient has an allergy to penicillin, allegedly. So patients often have a recorded history of contrast. So make sure you clarify exactly what those symptoms that they're endorsing as allergies look like. If it's a mild physiological reaction, like a little bit of nausea, or they just don't feel really well, a little headache, these are mild physiologic symptoms and we can give them supportive care. If they have a mild allergic reaction, like some itching, some pruritus, a little bit of sneezing, that's a mild allergic reaction and we can pre-medicate them. But if it's a severe allergic reaction, we can't do anything. There's no such thing as prophylaxis for anaphylaxis. If it's a severe allergic reaction, we're worried about their airway, there's nothing we can do. They cannot get contrast. Okay, so your patient has mild allergies. Let's pre-medicate them. How do you pre-medicate? This is a sample of the regimens that we have here at my institution. There are longer regimens, as you can see, and shorter regimens. The longer one is the one we prefer. It's very standard. Your seniors will also be familiar with this. But the shorter ones, let's say you're in the ED, the patient needs a stat study or an urgent study, you can do the shorter one. Okay. Let's move on. Chest basics. These are real questions that I was asked as an intern. How is this chest radiograph taken? People love asking this question. So to answer that question, we first have to think about how shadow puppets work. So we've all held up a flashlight, put our bunny ears up, and then made a shadow puppet on the wall. When you hold your hand really close to the flashlight and your hand really far from the wall, the shadow becomes very big. But if you hold the flashlight very far from your hand and your hand's just really close to the wall, it's about the same size. And that's true for how we shoot radiographs. So when we shoot a chest radiograph, we can have the X-ray generator behind us, and our heart, which sits in the front of our chest, is closer to the detector, which means that the shadow of our heart is going to be about the same size as our heart actually is in our chest. But when we shoot anterior posterior, this is more like what we might do on the floor upstairs with our portable chest radiographs. Our heart, which sits in the front of our chest, is closer to the beam generator, or closer to the flashlight, if you will, and further from the wall. And so our heart shadow will look bigger. So knowing that, we might ask ourselves, which one of these is shot posterior to anterior and which one is shot anterior to posterior? If we take a look, think about it for a second, we might see that the one on the screen left has a more smaller appearing heart, and the one on screen right has a more exaggerated heart. So it's posterior anterior versus anterior posterior. Other things that matter when they ask you how this radiograph was shot is the angle. This is kyphotic, looking down on the chest, or lordotic, looking up. And the position of the patient matters as well. This is my scary cartoon guy with a pleural effusion. So when they're upright or semi-erect or supine, how the chest looks, how the pleural looks, all of those things will look different. Okay, they love to just point at something and ask you what it is as well. So let's run through some of the basics. Your posterior ribs are the ones that look flatter, and your anterior ribs wrap down around the front. You have your right hilum and your left hilum, and then you have your mediastinum. This is your right diaphragm, hemidiaphragm, and your left hemidiaphragm. And you have your clavicles at the top coming back around here, and then your scapula, and your tip of your scapula actually curves down here where it's marked. Okay, they also love pointing out like different parts of the mediastinum and asking you what's causing that border. So this is your superior vena cava, your right atrium, your aortic knob, so that arch as it comes up and down into the descending, your left pulmonary artery, your left atrial appendage, or like the little attic or side room of your left atrium, and then your left ventricle. Additionally, there are a couple other lines that are really important. This is your right paratracheal stripe, and I'll kind of talk about it a little bit more later. And this is your aortopulmonary window. So these are actually places that we look. If they end up being like opacified, like whited out, there's something bulky there, we start to ask ourselves if there are like lymph nodes or masses there. Then this is that descending aorta. So we saw the aortic knob, and this is the aorta as it starts to go down through the chest into our abdomen. This is your costophrenic angle. You've probably heard about this. These are our lateral costophrenic angles where our thorax meets the diaphragms. Okay, how do you approach a chest radiograph? A common way that we're taught when we're not in radiology is the ABCDE method. This is airway, bones, cardiac, diaphragm and deformities, and then everything else. This way works. Whatever you remember is the best way to do it. So my search pattern is totally different. It's technique, lines and tubes, inflation, lung parenchyma, pleura, mediastinum, and bones. As long as you stick to a pattern, that's the most important part. All right, so let's go back and get into our cases. This is gonna happen to you when you're on rounds, post ICU nights, it's 11 a.m., you wanna go home, they'll pull up a radiograph for you. So we'll get in a little practice. If everyone can go to pollev.com or just send VU Medicine to 22333, I'll give you guys a second to do that. All right, so we'll do this first case. So this is a chest radiograph. You have the PA view and you have the lateral view, and somewhere in here they have a pneumonia. Your choices are A, right upper lobe, B, middle lobe, C, lingula, and D, right lower lobe. Where do we think it is? Great, okay, I hope this worked. Okay, middle lobe, all right. Got a couple answers, I love it. Let's see. Good job. Okay, so I think most of y'all caught on to this, but the way that we know that it's the middle lobe, there are two ways. So first, let's start with the lateral. We have our upper lobe and our lower lobe. Um, the lower lobe sits more posteriorly. Our upper lobe is here near the apex of the lung. And then the middle lobe is where we see this more opacified region. It's somewhat wedge-shaped, right? And it's here in the front of the chest. The way that we can also localize it is here we see on our posterior anterior view that this contour of the right atrium is somewhat blurred. This line is not as distinct. This is something that we call the silhouette sign. So when you're trying to localize where something is in the lung, we use those lines that we talked about, those contours of the mediastinum, to localize. Can you follow that contour everywhere? Where you see that border blurred, that means there's something butting up against that contour, and that's where it is. So our right atrium kind of butts up against the middle lobe. So when we can't see that contour, we start to ask ourselves, what's going on in the middle lobe that I can't see that line as clearly? Similarly, like I kind of mentioned before, we use things like the stripe and the paratracheal stripe and the aortic knob. If we can't see those lines very well or those spaces very well, we start to think that something might be there. Good job, guys. Okay, let's move on. This is a similar question. Where's this pneumonia? We also have a PA view and a lateral view. Give you a couple seconds to look at it. Okay, where do we think this one is? We said lingula and left lower lobe. Okay, I like this. I like what you guys are thinking. Let's take a look. It is the left lower lobe. So this is how we know. Okay, so the lingula and the left lower lobe tells me that y'all saw exactly what I wanted you to see. You saw it was somewhere down here, maybe, right behind this cardiac border. Y'all notice that this was more opacified or more whited out than you might expect. But then the question is exactly like we were trying to debate between, is it in the lingula? Is it in the front of the left chest, lower lobe? Or is it kind of, or lower lung? Or is it further in the back? And the way that we can tell is let's look back here, right? This, I don't know if you can see my arrow, but the apical and anterior portion is the upper lobe. The posterior and lower portion is the lower lobe. And this here is actually where it's circled on the lateral is where the pneumonia is. This is actually a sign that's called the spine sign. So your spine in your thoracic spine should appear more lucent as the vertebra descend. That's just the appearance that it has. When there is a pneumonia or something in the lower lobes, whether right or left, it'll create an opacity that gives the appearance of the spine, the vertebra becoming more opacified. And we call that the spine sign. It indicates to us that something is actually in the lower lobe. When we put that together with our anterior posterior or posterior anterior radiographs and see that there's an opacity behind the heart, we know that it's in the left lower lobe. Great work. All right, moving on to something a little different. Patient with heart failure misses their diuretics for a couple days. What do we think is going on? Do they have effusions, a bronchitis, pulmonary interstitial edema, or do they have multifocal pneumonia? What did you guys say? 100%. Perfect. All right. Good job, y'all. Okay, so you saw exactly what needed to be seen, which is that this patient has pulmonary edema. They have these classic curly B lines, which somebody will ask you about. And the way that pulmonary edema works, right? So in this patient, for example, they have heart failure. So when you have heart failure, your ejection fraction, your heart, it's not working like it's supposed to, and the fluid is backing up into your lungs. The first place it backs up to is here in your interstitium. So this is your secondary pulmonary lobule. And then you have sort of that hexagon, that's your interstitium. And that fluid is backing up into the interstitium and causing these lines that you're able to see. There's also alveolar edema. That's when the fluid is now within your air spaces, and that looks a little bit different. So you can see the curly B lines, but then here on the screen right, you can see this patient has also alveolar edema. There's fluffy airspace opacities. When we see alveolar edema, we often can see what's called the bat wing sign, and that's just where those opacities kind of gather around your hyla and create kind of a bat wing appearance of airspace opacity centrally on both sides. Okay, something different again. Case number 4, a patient with a lung biopsy earlier today comes back with chest pain and shortness of breath. Do you think they have a non-tension pneumothorax, a tension pneumothorax? Do they have atelectasis in their left lung, or do they have a cystic right lung? Okay, let's see. Amazing. Y'all are doing wonderful. So they have a tension pneumothorax. Okay, so the way that we know, which y'all know, it's a tension pneumothorax, is first you pick up on the fact that this patient has air in their pleural space. They have absent lung markings on the right side of their chest, but it's tension because they are pushing things away. So the pressure within that space has now increased, so that you have mediastinal shift away from the pneumothorax. You can see that their trachea has been pushed, their whole mediastinum has kind of shifted over to the left side. They also have increased rib spaces, which can be a subtle clue sometimes. This is a companion case. Patient with a lung biopsy earlier today, so same history, comes back with chest pain and shortness of breath. What do they have? Is it a right-sided pneumonia, bronchospasm, pneumomediastinum, or a left-sided pneumothorax? Okay. So this one's a little trickier, but y'all are right. They do have a left-sided pneumothorax. This is not as obvious as the last one, right? So the last one was a tension pneumothorax. Everything was shifted over to the left side. This one is a little more subtle. So here we can see right on the periphery, it's easier to tell in the lower portions of that left lung that there are absent left markings. We can see a subtle pleural line. And then just if you kind of squint your eyes and take a look, that whole left, like that left side, you see it's a little bit more lucent. So this is a zoomed in version, so it's easier to tell when you zoomed in. It can be hard to tell on the computer screens as well. But there you can see that they have a pleural line, and then they have lung markings closer to their chest, and then further on the periphery, they don't have lung markings. One thing not to be faked out by is pneumothorax versus a skin fold. So on the screen left, we can see that that's a true pneumothorax. That's what I showed you earlier. The pleura has actually a white line, or it looks like a white line. And then when it's truly a pneumothorax, you'll see the lung on the inside, so it'll be more gray, and then it'll be darker on the outside. Now, if you have a skin fold, there is not a true white pleural line. So what I've pointed at there is that kind of diagonal dark line, that's a skin fold. So your skin is like pushing up against itself and then causing a fold. So what you'll actually see, instead of just sort of a uniform kind of gray lung, is you'll actually see it becoming on a gradient more and more opacified, and then boom, a black skin fold. And that often can fake people out near the apical lung as a pneumothorax, but it's just a skin fold. Okay, next case. This patient had a motor vehicle crash and they are now intubated. You can see that they are on the board. They have a C-collar in place. What do they have? Do they have a right-sided pneumonia? Do they have bronchospasm? Do you see a pneumomediastinum? Or do they have a left-sided pneumothorax? Bronchospasm, pneumomediastinum, or left-sided pneumothorax? Okay, let's talk about it. So the answer is a left-sided pneumothorax. I can't really see, maybe if you don't see anything, maybe bronchospasm is a great guess. But yeah, I can't really see that. Like there's not going to be a really good image finding if someone has just spasm. But the most important thing to note here is that two things. One, the patient is supine, right? So we talked about how positioning matters, and how things in the pleural space will look different when you're supine. And the other thing is here, your lateral costophrenic angle. So when this is deeper, this indicates to me a pneumothorax. Oh, and I do want to mention, pneumomediastinum is a great guess for this history. Patient has had a motor vehicle crash. That's a really good guess. What I would expect to see in a pneumomediastinum is I would expect to see air that's contouring here, this pneumomediastinum here. If you're looking at it and you're like, oh, there's a little bit of dark stuff here, maybe that's air, it should be more distinct than that. What our eyes do when we see the mediastinum in the lung is they create an illusion of a dark band. Those are called MAC bands. If you're actually seeing pneumomediastinum, it should be a darker sort of air lucency black line around the cardiac contour. So this deep angle that we see here, this is actually a sign called the deep sulcus sign. The reason that we have this here is this patient is supine, and that's how pneumothoraces appear sometimes when a patient is laying down. Because when you're laying down, air rises, right? And so the air will rise to the anterior portion of your chest. It's going to fill in that costophrenic angle like this, and it'll wrap around towards their side, right? So this patient, their head is to screen right and their feet is to screen left, and then you're going to see a deep sulcus as it comes to the front and then wraps around to the lateral costophrenic angle. That one was a tricky one. All right, let's do a different one. Patient with known hepatocellular carcinoma presents with shortness of breath and chest pain. Do they have, well, something abnormal is going on. Do they have a left lower lobe pneumonia, a left pleural effusion, a pericardial effusion, or a new mediastinal mass? Pericardial effusion, left pleural effusion, and new mediastinal mass. Okay, most of y'all guessed pericardial effusion, and you would be right. Nice work. Uh-oh. Okay, so this is a pericardial effusion, and the way that we want to approach that is we've noticed here, all of you picked up on that the opacity where our cardiac contour or mediastinum is different from how we would expect it to look. A good rule of thumb that you might be asked when you're being quizzed on morning rounds is, how do you know if the mediastinum looks wider? So the way that I like to go about it, just briefly, is the cardiac width should be about half the width of the whole thorax, and the upper mediastinum, around where your aortic arch is, should be about a third of width of the thorax. Now, we have gone over that when you're looking at anterior posterior versus posterior anterior, it can change the way the size of your heart looks. So this is really just a rule of thumb. This radiograph has a very classic appearance of a pericardial effusion. So instead of your heart, kind of pointing towards the left as it usually does, it looks widened on both sides. This is the water bottle sign that indicates to us usually that fluid has accumulated around the heart, and it's giving appearance of a widened cardiac contour. If it were a mediastinal mass, it's possible, but you would still see your cardiac contour most likely, and then you would see separate contour, an area of increased opacification where you have a mass, or you might see some of those lines differently. For example, something in the aortopulmonary window, you would see an additional contour. The other guess for left pericardial effusion, can I say for sure that this patient doesn't have a left left pleural effusion? I can't say for sure. You guys are picking up correctly on the fact that I don't see their lateral costophrenic angle on the left. But the main finding here that you've got to mention is that they probably have a pericardial effusion. Great. Okay, next case. Patient with cirrhosis presents with shortness of breath. What do we think they have? Do they have a right pleural effusion, a left-sided pneumothorax, a right lower lobe pneumonia, or is this a normal chest radiograph and I'm tricking you? Okay. Right pleural effusion and normal. Okay, this one is a sneaky one. They do have a right pleural effusion, but it looks pretty normal when you kind of glance at it. So what you really have to hone in on this one is that you can't see their right costophrenic angle as well. But this one's tricky because their diaphragm still looks normal, right? Like you see their right side diaphragm, you can follow most of that contour. It's just that little angle where you don't see that crisp edge, right? When you look at the left side of their chest, it's nice and crispy, but on the right, not so much. And you might even be able to hallucinate something that kind of looks like a meniscus. So pleural effusions, when you're just looking at the chest dead on, can be a little bit hard to spot, like in this case. Partly, if you see one, it's at that point a pretty sizable pleural effusion. The reason is because your posterior costophrenic angles, so you can see that on the lateral where I've marked out that where a pleural effusion would go, that's actually deeper down than your lateral. So when it's posterior, you can see a small pleural effusion, like 50 cc's. By the time it's blunting that lateral costophrenic angle, you have probably about 200 cc's of pleural effusion. So when you're looking at it, just if you have a lateral, use the lateral because that's when you can really catch those really small pleural effusions. Good job on that one. Okay, so that was the last one. Just kind of a quick and dirty of chest radiographs. In summary, RAD's life is a collaborative and flexible life. You can really explore a lot of things. You can see patients, work with different kinds of specialties. It's a really fun time. When you're a sub-I or fourth-year med student or an intern, you may have many questions for radiology. Just always give us a shout, say hi, introduce yourself, and let us know what we can help you with clear questions and patient information. And then chest basics, they love to quiz you on them. Most important thing is when in doubt, just go through your search patterns, whether A, B, C, D, E, or whatever pattern you use, and say what you know if you don't know the answer. So that's it. Thank you all very much. If you have questions, please don't hesitate to reach out to me. My email is just my name, dora.chen@vumc.org, and best of luck with everything. Thank you for your time.
Great. Thank you so much, Dora. We'll take like a 5-minute break for intermission. We'll come back at 11:14 and we'll start with the rest of the boot camp.
Great. Welcome back, everyone. Okay, we are going to get started with the next portion of this radiology boot camp. My name is Jennifer. I am one of the faculty at Vanderbilt now. Done a bunch of training to get here, basically hopping between North Carolina and Tennessee, and a brief stop in Boston. Sorry, just trying to fix my screen. All right, today I'm going to be talking about abdomen and the head. Dora is actually one of our residents at Vanderbilt, and she's amazing. So that was a great presentation from her. I am going to also use Poll Everywhere. So it's the same website that Dora was using, but in case you forgot, it's pollev.com/VUmedicine. And this QR code should also take you to that same place, or you can text VU Medicine to 22333. All right. So just starting with the abdomen, we're going to first talk about radiographs. We'll talk about a small bowel follow through, and then we'll talk about a CT abdomen pelvis. So starting with patient positioning of an abdominal radiograph, there's a couple main ways that we obtain abdominal x-rays. The first is in an upright view. So this is what's preferred. This is a patient standing up, kind of similar to a chest x-ray. The x-ray generator is in front of them, the detector is behind them. So this is from front to back. In addition, we also can obtain abdominal radiographs in a supine position. So again, most commonly used in the hospital when a patient can't sit up or they can't stand up. Here, the x-ray generator is in front of them, the detector is again behind. And then the last one is this special technique we use, which we refer to as the left lateral decubitus position, which basically describes how the patient is laying on the table. So here you can see the patient is laying on their left side with the x-ray tube in front of them and the detector behind them. All of these have different uses, and we'll talk a little bit about them as we move forward. So just like Dora was saying, it's extremely important in radiology in every imaging study to have an approach, a systematic approach to how you look at the imaging study so that we don't miss anything. In this case, this is an example of an approach to an abdominal radiograph. It's the acronym ABDOX. So A for air, B for bowel, D for dense things, O for organs and soft tissues, and X for external objects. This is the search pattern that I use. Again, this evolves over time, and you'll find your own pattern or whatever it is that makes the most sense for you to make sure they don't miss anything. So I basically look at lines and tubes first, then I look at all the dark stuff, then the bright stuff, and then I look at everything else. Okay, abdominal radiographs in general are really only good for a few things. And we'll talk about these 4 things moving forward. So the first thing is an enteric tube. So they're very, very good at looking at enteric tubes, of which there are multiple types. Here's just a few of the examples of the types. There's the Salem sump, which is a suction tube, and the Dopphoff and the small bore feeding tubes at the bottom. I bring this up because they have a different appearance on radiograph. So here you can see that the suction tube has this gap in the radiodense line that's made by the manufacturer. And that helps tell you that the most proximal side hole, the side hole that is closest to the mouth is where that line is, where that gap is. And then there's more side holes more distally. That's in comparison to the feeding tube, in which there's no side hole, and it's just the question of where the tip is on a radiograph. Okay, so a typical enteric tube location, or the normal location of an enteric tube, it should be in a pre-pyloric position. It should be entering midline to the level of the diaphragm, not along the course of the bronchi, which we just talked about. And then the tip should go beyond the GE junction, which is at about the level of the diaphragm, and then it should terminate in the left upper quadrant, since that's where your stomach lives. In comparison, you can also have a feeding tube placed post-pyloric, in which case now you have to follow the course of the stomach and then into the pylorus and then through some varying distance of the duodenum. So here you can see that C shape of the duodenum. In this case, this feeding tube is post-pyloric. It's going along the course that we expect for the duodenum. Okay, we get this question all the time. You'll see us in radiographs, you'll see us say the tip projects over the stomach or the tip projects over the left upper quadrant, something like that. And then we always get the question of, can we use it? So we can tell you where we think the location is radiographically, but I can't really tell whether it's functioning, whether it's aspirating, whether it's flushing correctly, whether it's suctioning okay. So most of the time, you'll just see us comment on the location of it, since that's what we're identifying radiographically. All right, here is our first poll. So this is some practice questions with enteric tubes. So this should show up on your screen. You can select where you think the location of this enteric tube is. Unfortunately, my numbers are cut off, so I can't see it, but that's okay. We'll continue on. All right, we have most of you saying that this is in the esophagus, and you would be correct that this enteric tube, so here was that image, this is the enteric tube. You can see the proximal side hole here, so this is the suction type tube. You can see that the side hole and the tip, both of them are in the esophagus, and they are not going past the level of the diaphragm as we have talked about before, like they should be in a typical patient. All right, here's another practice case. So this case again asks you, where is the location of the enteric tube? Right, excellent. Most of you identified correctly that this is in the upper esophagus, which we will talk about now. So here we can see this radiodense line, that is the enteric tube. The enteric tube comes down the midline, but then all of a sudden it turns around in the middle of the esophagus, goes back up in the esophagus, and then it terminates in the upper portion here. So the correct answer here is that this tube is looped in the esophagus with the tip in the upper esophagus. And this would probably receive an alert. You would probably receive an alert if you were taking care of this patient, since this is not the correct position of an enteric tube, and this should be repositioned for more optimal function. All right, I think this might be the last example practice case that we have. This is again a question of, where is this feeding tube? Or I guess I should be more specific. Where is the tip of this feeding tube? All right, amazing. Most of you have gotten that. This is in the left bronchus. So here you can see, let's move forward. So here you can see again this Dopphoff tube, or this feeding tube, that looks like it's coming down midline. It's doing pretty well all the way to the middle. When it starts veering off towards the right, it loops in the right and then heads back towards the middle, and then it ends in the left chest. So this is definitely not where the esophagus is supposed to be. Remember, the esophagus should stay midline the entire time through the chest. So in this case, this is actually looping in the trachea, in the right main bronchus, coming back across the carina, and then ending with the tip in the left lower lobe bronchus. So again, you would probably receive an alert about this. We definitely do not want to feed this patient, as we would just be feeding their lung and not their stomach, as we would want. All right, moving forward, we'll talk a little bit more about some other findings aside from just enteric tubes. So this is a case that's asking, what is the most likely diagnosis in this case? All right. Amazing. We've got most of you saying the correct answer, which is a retained foreign body. External device is a pretty good guess, but that would not be quite correct in this case. And then a kidney stone is also not evident on this image. So here you can see that there is an enteric tube, but this looks to be okay. It's ending in the left upper quadrant or projecting over the left upper quadrant, which is okay. But here in the right lower quadrant, you see this curvilinear density that doesn't really look like anything in particular that we would expect in the body. This is probably just a radiopaque marker. But here you can see that this is actually what a laparotomy sponge looks like on radiograph. So this blue line, or this blue part of the sponge, is actually made to be radiodense so that it shows up on a radiograph. And this is particularly useful in cases where patients go to the OR and they need to the patient because they're bleeding, and then sometimes they lose count in the OR, and they might get an abdominal radiograph to see if they've left anything in the body. So this is an example of an accidental retained foreign body from a laparotomy sponge. All right, excellent job. And this is just another fun case. There's all kinds of things you can see in radiology. This is a fun case of someone who had swallowed this as a foreign body. So here you can see again in the right lower quadrant, there are two, I think they're AirPods. I actually don't know what brand they are, but they look like earbuds that this patient swallowed. So all kinds of fun and crazy things that we see. All right, this is a different case. The question is, what's the most likely diagnosis? You get two different views of this baby. All right, amazing. Most of you have gotten, we are in the abdomen, so you've got to choose an abdominal finding, not a pneumothorax, but it's a good thought. We always want to make sure that we look at everywhere in the image. This is an example of pneumoperitoneum, which most of you identified, and we'll go over this in a second. So I think that the most important thing to think about, just like Dora was mentioning, is to consider how a radiograph was obtained. So in this case, this radiograph on screen left, this was obtained in a supine position, whereas in this case, this was obtained in a right lateral decubitus position. So in this image, there's what you can see is that there's this hazy darkness that's overlying the entire abdomen. And that's in comparison to that when the patient's laying on their right side. Now you can see that there's this hypodense area, all of this black area that's going non-dependently to the patient's left side because now they're on their right side. And so this is an example of pneumoperitoneum. This is free air that is here layering anteriorly or collecting anteriorly, and here it is collecting on the left side because of patient positioning, because there's a difference in these two images and how the patient was laying. So really important to think about. That's why we talked about at the beginning, what are some of the different imaging positions that we use, because that can affect what kinds of findings you're going to see. Okay, so just a little bit about free air. Like we talked about, we really want to think about patient positioning to think about where air is going to go. The most common causes are a perforated viscus, or sometimes it's iatrogenic, particularly if someone has just had surgery. This is an example of an upright radiograph. There are many different signs, but this is one of them in which you see a continuous diaphragm sign. So you see that normally you can just see the diaphragm on one side, and then you can't see the part in the middle leading to the other side. In this case, you can see air underneath the middle part of the diaphragm, as well as under the right and left side too, as in addition. And then this is an example of a supine radiograph, just like the other one we saw earlier. In this case, air is collecting anteriorly in the patient. It's going to outline this radiodense line here, and that is actually the falciform ligament. So the football sign, the seams of the football are the falciform ligament, and then the rest of the football is this air that's collecting around it. All right, so many different signs that we see. These are just two examples of signs you can see on a radiograph for free air. All right, moving on to small bowel obstruction versus ileus. There is a differential for dilated bowel loops, which is mostly these two entities. There's a general guideline. I say rule in quotes because it's not a hard and fast rule, but 369 is the general guideline in which small bowel loops are typically about 3 centimeters in caliber in width. 6 centimeters is about the size of the colon, except for the cecum and the rectum, which can get up to 9 centimeters. So that's the 369 rule. In this case, you can see two different examples on screen left. you have an example of centrally dilated small bowel loops, and then there's a lack of gas elsewhere in the abdomen. And then on screen right, you can see that there's just gas everywhere. So there's small bowel, there's large bowel, there's all kinds of gas all over the bowel or all over the abdomen. So screen left is an example of a small bowel obstruction, and screen right is an example of ileus. Another thing that can be helpful is that you can have these shorter air fluid levels in a small bowel obstruction compared to these longer air fluid levels in an ileus. So that's another clue. It's not, it's not a great sign, but sometimes it can be helpful in identifying whether something is an SBO versus an ileus. Okay, but I do want to point out that radiographs are really not that sensitive for an SBO, and sometimes it can be really, really hard to tell the difference. We oftentimes use the clinical history and exam in order to help give us some more information, but really that'll be something that you as a clinician, someone, if you order an abdominal radiograph trying to tell the difference, you'll be able to provide some more clinical context for that. But when in doubt, you can always send them to a CT because that'll be way more sensitive for differentiating between SBO and ileus. All right, so as an example of that, do you think that this patient has an SBO based on this radiograph? So what I see is really just a scattered gas pattern. It's very nonspecific. There's some gas in small bowel loops and there's some gas in large bowel loops, like in this loop here and here. But this patient did end up getting a CT and they did have an SBO. Here you can see that they have a bunch of fluid-filled small bowel loops that mostly have fluid in them with just a little bit of gas. And so that's why we don't see it very well on this radiograph, because you're not going to be able to see fluid as a distinct density compared to the rest of the abdomen, the rest of the soft tissue. You're really relying on the bowel loops being filled with gas to be able to identify an SBO. So this is just an example to show you that radiographs are not always super sensitive for identifying a true SBO. And if you need to, you can send them to CT. Okay, so these are some of the things we talked about for abdominal radiographs. We talked about radiopaque foreign bodies. We talked about pneumoperitoneum or free air, and then we talked about differentiating between SBO and ileus. All right, moving through a small bowel follow-through. So a small bowel follow-through is typically performed on the floor. We start with a scout image. We give the patient about 200 to 300 cc's of PO contrast. It can be any type of contrast, but this is what we typically use. And then we image at timed intervals at specific times within 24 hours to look for contrast in the cecum. We want to see that contrast that we gave them through their mouth progress through the bowel so that we show that there's no obstruction. The normal small bowel transit time is about 30 to 120 minutes. That's definitely really variable in the hospital. But we do this because there have been studies to show that the presence of contrast in the colon at 24 hours predicts resolution of an SBO with a very high sensitivity and specificity. So if we can get contrast into the colon before 24 hours, that suggests they do not have at least a high-grade SBO. Okay, so here's an example. This is the scout image. We always take a scout image first to make sure that there's no contrast elsewhere in the abdomen that's already present, and just to get a lay of the land. Here we can see that this is a 1 hour image after they have gotten the contrast through their mouth. So now you can see there's contrast in the stomach, there's contrast in a bunch of dilated small bowel loops, but we don't really see contrast in the colon yet. So we asked for another image. This was a 5 hour image. And here you can see that there's less contrast in the stomach. It's now progressing through more small bowel loops. And then you also see a part of the colon coming into view. So you see this is the right-sided colon and you can see part of the left-sided colon. So at this point, we can say that the contrast made it through the small bowel, it made it into the colon, and therefore this patient does not have a high-grade bowel obstruction. Okay, so that's what we are talking about when we say a small bowel follow-through. The next thing we'll talk about is a little bit about CT abdomen pelvis. We'll start with a little bit about IV contrast. So these are 4 different phases of timing for a CT abdomen pelvis. The top left shows you a non-contrast view. Non-contrast phases are typically good for patients, especially when you're looking for things that are intrinsically bright, so like a stone or like a kidney stone, like in this image. Anytime someone has poor renal function, we can also get a non-contrast study that doesn't use IV contrast, which can be nephrotoxic. On the upper right corner, this is an example of a late arterial phase. So here you can see a lot of contrast that's in the artery. This is the aorta here, and less in the vein. This is the IVC. So these are really good for looking at bleeds. We also use it to characterize masses. Bottom left corner is a portal venous phase. This is our standard phase of imaging in the CT in the abdomen and pelvis. So if you just order a CT abdomen and pelvis with contrast for someone who has right lower quadrant pain, this is the phase you're going to get. Here you can see a little bit less in the aorta and then more that's coming into the veins. Again, we use this as our standard evaluation. It can also help us characterize masses. And then the last one we'll talk about is a delayed phase. In this case, you now see that the contrast has made it through basically all of the organs and it's being excreted by the kidneys. So these are the kidneys with contrast in the collecting systems. This is often used to evaluate for ureteral injuries or other masses. And it can also help characterize the mass in the abdomen. All right, we can also give PO contrast or oral contrast. In this case, there are two main types of contrast. There's negative oral contrast, which just shows up as this darker gray. It shows up as fluid attenuation. And this is often given in the setting of an enterography study. And then we can also give positive oral contrast, which shows up bright in the bowel. So the patient drinks this oral contrast, just like the small bowel follow through, and then we take an image. And this is very often used in the setting of looking for a leak from the bowel. Okay, so that's a little bit about contrast. Reading a CT abdomen pelvis, we really do not have time to go through all this, but again, it's most important to be systematic. This is just an example website that'll show you some introductory lectures to reviewing an abdominal CT, or you can do a radiology residency and you'll learn the same thing. Okay, the next thing we'll talk about is some key findings. So this is an example of fat stranding. Here you can see that there is a little bit of this hazy attenuation that is in the fat around this dilated tubular structure in the right lower quadrant. So this would be what we would call fat stranding. Fat stranding is this haziness that's in something that's supposed to be cleanly dark, like this. This tells us that there's inflammation, but it doesn't tell us, other than that, it's not really a diagnosis. It just tells us that there's something that's inflamed, but it does help us localize the pathology. So once we see fat stranding, we can hone in on what organs the fat stranding is around. In this case, this is around the appendix. And so this is an example of acute appendicitis. So there's inflammation seen as fat stranding around a dilated appendix, so appendicitis. Here are two other examples of fat stranding around different organs. In this case, you see this haziness around around the gallbladder in the right upper quadrant, which is very dilated. So this is an example of acute cholecystitis, so inflammation around the gallbladder. And then finally on screen right, you can see that there's this fat stranding or this increased hazy attenuation that's kind of in the center of the abdomen. It's mostly surrounding the pancreas here. So this is an example of pancreatitis. So this is inflammation centered around the pancreas that looks slightly edematous. That is pancreatitis. Okay, so that's the utility of fat stranding. It just helps tell you where inflammation is. All right, this is a different case. That is a poll. The question is, what would you do next? Okay, amazing. I'm really glad that no one chose that they would eat a sandwich because although it's tasty, you definitely should take care of this patient first. All right, so the answer here is to stat page vascular, and we will talk about that now. If you chose the answer A, you would have been correct. All right, so the answer here is that this is a ruptured abdominal aortic aneurysm. You can see here that there is this very large circular structure in the middle of the abdomen, some of which is filled with contrast and the rest of it is not. And then in the left retroperitoneum and peritoneum, you have this extensive fluid. It's kind of bright fluid that is just filling the left side of the abdomen. So this is not just a big aorta. This is an aorta that has ruptured. This patient is bleeding out into their belly. So this is not just, an aneurysm. They just need follow-up over time to make sure it doesn't rupture. It has already ruptured. So in this case, this is like worst case scenario. This is what we look for in aneurysms. This is why we follow aneurysms, is because they can rupture. And so this patient needs to be seen by vascular so that they get taken to fix this ruptured aneurysm. Okay. So that is, again, the dilated aorta, and then this is the blood that's sitting in their belly because of this rupture. All right, this is another case. The question is again, what would you do next? This one is definitely a sneakier case. Okay, amazing. All right, most of you, I kind of like that some people said that you would order a CTA of the abdomen and pelvis because you identified that this is a non-contrast study, but that would just give us more work to do. And in this case, we don't need the more work. In fact, the person that does need to go do some work is surgery. You could, theoretically, I'm surprised no one chose that they would call radiology. You can always call us if you have questions about a study. Again, keeping in mind what Dora talked about how you talk to us, since we do get a lot of interruptions. Okay, but the answer here is that you would call surgery, which most of you said. Okay, and the reason that you would do that is because in this case of a non-contrast CT of the abdomen and pelvis, you see that there are these areas of darkness, these areas of black that are in bowel loops. So all of this is in bowel, which is good. That's fine. But there's also areas that are dark, that are the same black, that do not look like they're in bowel loops. Like this does not look like it's in a bowel loop. This does not look like it's in a bowel loop. And you can even change the window, which I didn't give you, so it's kind of unfair. But you can change the window to a lung window to make these findings stand out even more. So this is the same patient. We've now switched to a lung window, and here you can really see that the black of the air stands out a lot more against the soft tissue. So this is a case of free air. This is pneumoperitoneum. And like we talked about earlier, the most common pathologic cause is perforated viscus, or that's what we worry about the most. And so it would be important to call surgery to see whether they have a peritonitic abdomen, whether they need to get taken to the OR. All right, so that is an example of free air. Okay, so these are some of the things we talked about. Again, CT abdomen pelvis is way too big to cover in this 30-minute talk. So these are some of the things we talked about as useful tools. We talked about fat straining as a sign of inflammation. We talked about not just an abdominal aortic aneurysm, but a ruptured aneurysm being an urgent finding. And then we talked about free air. And we talked about how we can use lung windows to really differentiate gas from the rest of the soft tissue. All right, moving to the head. This is our last topic that I'm talking about. So in the head, we'll talk about CTs for a little, we'll talk about intracranial blood, and then we'll talk about MRI. So this is a very, very basic approach to head CT. It's important to use symmetry since the brain is a pretty symmetric organ. And then we want to make sure we use all planes. So here we have axial, coronal, and sagittal views. And then these are just some of the things we look for. We look for blood, hydrocephalus, mass effect or midline shift, and gray-white differentiation. So usually neuroradiologists have some kind of pattern of these things that they're looking for, whether that's by this order here or whether they go more anatomically. Okay, so we'll talk first about intracranial blood. So this is a poll. I want you to select what you think is subdural hemorrhage. A 50-50 shot. So. Okay, amazing. I kind of gave the answer away, but yes, you're all right that this image screen left is a subdural hemorrhage. Okay, so screen left was a subdural, screen right was an epidural. Just talking a little bit about the differences between the two. Subdurals have this concave shape where it looks like a banana or a crescent. Here you can see on the right of the patient. Typically, what's injured is a bridging vein in a subdural hemorrhage. And then typically they do not have an overlying fracture, and it's more commonly seen in an older patient. That's in comparison to an epidural. Epidurals typically have this more convex or lenticular shape, like a lemon. Typically, the injured vessel is the middle meningeal artery, and they often have an overlying calvarial fracture. And then they often present with this lucid interval. So they're like out for a little bit, they come back for a few minutes, and then they lose consciousness again. So that's the more typical presenting pattern of an epidural hemorrhage. Okay, this is a different type of intracranial hemorrhage. Okay, amazing. Most of you have gotten that this is a subarachnoid hemorrhage, which is the correct answer. And we'll go over some of the other types of bleeds. So starting with this one on the left, you can see that this is an intraparenchymal hemorrhage. So this is just in the brain parenchyma. It shows up as this blob of bright. This is most commonly seen in the setting of hypertension, occasionally in amyloidosis, which is much more rare. This image, which is what we saw on our poll, that is an example of subarachnoid hemorrhage. In subarachnoid hemorrhage, most commonly the causes are aneurysm or trauma. Patients typically present with a thunderclap headache. And then the important complications to worry about is hydrocephalus and vasospasm. So blood coating arteries is not a good thing. Arteries do not like to be coated with blood around them. It's very irritating, and so it can vasospasm. It can basically like constrict, and that can cause problems. And then this last example is a case of intraventricular hemorrhage. Here you can see the bright that's in the ventricles, in the lateral ventricles. Most commonly, this is from hypertension or an aneurysm, or it can be extension from any of these other blood intracranial hemorrhage patterns. And then here we want to watch for hydrocephalus. Blood tends to be kind of gooey, and so it can block the outflow of the ventricles, and so it can cause obstruction of your ventricles, which leads to hydrocephalus. All right, and then this is just a diagram showing you different types of intracranial hemorrhage, which we talked about. Okay, the last topic I'll talk about is MRI sequences. I feel like this is something that you don't often get, and so I wanted to focus on it a little bit. This is an example of a T1 weighted image. In a T1 weighted image, white matter is white, which is in the center here, and gray matter is gray, and CSF is dark. So it's a typical anatomic, it's best for looking at anatomy, and so it has the typical anatomy colors. So white is white, gray is gray, and then CSF is dark. Okay, this is an example of a T2 weighted sequence. So here you can see that CSF is bright, white is gray, so the white matter is gray here, and the gray matter is brighter. So the white matter is gray matter is brighter, and then CSF is bright. That helps tell you this is a T2. Okay, this is the one that everyone always gets confused with the T1 because you look at it and you see that the CSF is dark. But the difference here is that the white matter is gray and the gray matter is whiter. And so this is an example of a flare. A flare stands for fluid attenuated inversion recovery, in which you take a T2 image, which we just saw, and you suppress the CSF, you make it dark, and that's why the CSF shows up as dark. So again, this is just a T2 weighted image, and you just cut out the fluid. You take out the fluid and make it dark. So white matter's gray matter's bright, just like a T2, but in this case, CSF is dark. Okay, this is our T1 for comparison. Remember that white is white, gray is gray on a T1. Again, CSF is dark in both. Okay, this is an sagittal image. This also is a T1, but in this case, we've given contrast, and you can tell that because the vessels are bright. People also like to say that the nose knows. So you can look at the nasal mucosa, which is here, and the nasal mucosa enhances very readily on a contrasted image. So here you can see the nasal mucosa enhancing, the vessels are bright, therefore this is a post-contrast T1. This is an example of a pre-contrast T1 to show you the difference between the nasal mucosa as well as the vessel. Okay, and then the last two we'll talk about are these two, both of which have this pretty crappy resolution compared to the other ones. Here we just see like brain parenchyma, that's it. We don't see the scalp, we don't see the bone around. So these two both have this look where it's just crappy resolution. So image on the left is a DWI, which is a diffusion weighted image. And then ADC is on the right, an apparent diffusion coefficient. So in ADC, CSF is bright, DWI, CSF is dark, but they both have pretty bad resolution. The reason you need both is because you have to see something as being both bright and dark, bright on DWI and dark on ADC in order to call it restricted diffusion. So it has to be bright on DWI, dark on ADC to be restricted diffusion. The reason for that is because these are T2 weighted sequences. So they have typical T2 characteristics, which means that fluid should be bright. This is an example of a phenomenon that we call T2 shine through. So if something is both bright on DWI and bright on ADC, it is not restricted diffusion. It's just showing up bright because it's supposed to be bright on T2. And like I said, DWI and ADC are T2 weighted sequences. Okay, so again, in order for something to be restricting diffusion, it has to be bright on DWI and dark on ADC. Otherwise, it could just be this artifact, which we call T2 shine through. Okay, we'll do just a couple practice cases. So this is a poll. I want you to select what the flare image is on these 6 images. There we go. Okay, amazing. Most of you have gotten, oh, sorry, this is the wrong slide. Okay, most of you have gotten that this is the flare, this is a flare image in the middle here. So those of you who chose this one, you are correct. This is a flare, we'll talk about it in a second. Okay, and then the next slide is for DWI. I don't know, I think I might have done this wrong, so I don't know if you can change your answers now. But this image here is a DWI. Okay, we'll talk about these together. Okay, so top left, white is white, gray is gray, CSF is dark. So that's T1. Free contrast, white is white, gray is gray. This next image, the white matter is gray and the gray matter is brighter and the CSF is dark. So this is a T2 with suppression of the CSF, therefore this is a flare. Okay, we'll go to this bottom right. Again, white matter is gray matter is white, CSF is bright, therefore this is a T2. This is a typical T2. These two images both have really crappy resolution. CSF is bright in this one and dark in this one, therefore this one's DWI and this one's ADC. And then this bottom left, there's bright vessels, these lines in between, and so that's post-contrast T1. Okay, just like we talked about, just going through the sequences of what white matter, gray matter, and CSF look like. All right, and this is just a table to show you what we talked about already. These slides will be given out later, so you can use this for reference. Okay, and then this is just a summary of what we've talked about. Abdominal radiographs are good for a few things. Small bowel follicles can help evaluate for an SBO, CT, abdomen, pelvis, contrast use, and some important findings. And then finally, we talked about types of intracranial hemorrhage and how to tell what brain MRI sequence you're looking at. And that is the end of my slide set. I was 2 minutes over. I'm sorry, John. All right, thank you all for paying attention.
Hey guys, my name is John. I think we're gonna get started with the next part. So this will be the last part of the lecture today. So we'll be talking about radiology workflow. And then, so one thing to know is that this is dependent, especially on where you work. Different hospital systems sometimes have a different workflow for things. So a little bit about myself. So I grew up on the East Coast, was in the Midwest for med school, and then did all my training on the West Coast. So after fellowship, my wife and I moved back to LA. So currently I work in teleradiology for a group in Alaska and also for a group in California. So that's one of the things I like a lot about radiology is being able to work from home. If you guys have any questions about that, I'll be happy to answer about that. So I'm not going to show a lot of imaging interpretation cases, but I do want to just give you guys one case for my part of the lecture. So I'll have you guys take a look at the case on the next slide. So we'll do a poll everywhere for this one as well. So this is the X-ray here, and then the question I'm asking is essentially what is the most pertinent finding in terms of what system you think the most pertinent finding is in. So we'll give you guys a second to respond. Okay. All right. So we'll come back to this question a little bit later in the lecture. It's just like the case I wanted to show in the beginning. All right. So let's move on to the next part of the lecture. So we'll talk about common indications for imaging. So on this slide, if you've done any sort of radiology rotations, most likely you've come across a chart like this. This is from the American College of Radiology. This is the appropriateness criteria. Essentially, it's a list of multiple clinical diagnoses that have associated imaging findings, and they have a community of people who, describe those associated with the exams and then their recommendations for how appropriate it is. I think it's good teaching for letting people know what to order, but I think there's also certain limitations for this. So for example, in the case given here, this is based on clinical suspicion. So one thing is that you do have to have a good idea about what the etiology is. So a lot of times, as everyone's worked in the ED before, the patient's history and physical exam can be limiting. So at times you may not know exactly what you're looking for. The second thing that people have come up is patient expectation. So in this case, the recommended exam is going to be some sort of fluoroscopy study. Sometimes patients have done this exam before and it didn't yield any diagnostic results, so they want to do a CT instead. Or they come in and they want to do a certain exam. The third thing is that the equipment and personnel is not always available. So a patient coming in after hours into the ED, sometimes you're not going to be able to have fluoroscopy available. So then the next exam that's always available is going to be CT. So that's going to limit your ability to select the exam. And then finally, the last thing is going to be time. So when you're working in a busy clinical setting, usually you don't have time to look this up and see exactly what type of exam is appropriate. So I think another paradigm to think about is in terms of like how the exams performed and what kind of pathologies are the exams looking for. I'll go into that next. So this is just a chart in terms of the most common diagnoses for people coming into the ED. And so you can see most of these are going to be amenable to this paradigm here, which is going to be you do a radiograph first, and then depending on the results, you proceed to a CT. So sometimes this happens because you do a radiograph and then the diagnosis is seen, but you want more information in terms of management. So in this case on the radiograph here, you see dilated loops of small bowel that are central with airflow levels. So here you are pretty confident there's a small bowel obstruction here. But for the surgeon, you do want to know if there's a transition point where that is and if there's any complications of the small bowel obstruction. So you get a CT afterwards to get more information. So that's one clinical scenario. Another case is that, so on X-ray here, you do see that there's a consolidation in the right lower lung here. And the diagnosis is there, but you also want to make sure, confirm the diagnosis. So you can get a CT here, and then you do see the pneumonia in the lung here. And then this is another clinical scenario where on the radiograph, you don't really see an etiology for the patient's presentation. But when you get a CT, you do see they have a saddle pulmonary embolus here with definitely defect in the main pulmonary artery going to the right and left pulmonary arteries. So this is a case where the radiograph doesn't provide you with as much information as you had hoped it would, and then you go to a CT next, which provides you with a diagnosis. Sometimes you don't need a CT afterwards. So this is a case where a patient comes in with a fracture, and then what you see on radiograph is adequate enough for you to have a diagnosis. So typically, there's no subsequent CT in this paradigm, although sometimes if the fracture is very comminuted, then you would get CT to kind of address that in terms of delineating the pattern fracture. In other cases, you don't do radiograph first and you go straight to the CT. So in this case, we have a brain bleed, and on radiograph, it's not going to really show anything for the diagnosis, so you proceed directly to a CT. So beyond radiographs and CTs, ultrasound is also another part imaging modality you can use. The pros and cons of ultrasound. So one of the biggest pros for ultrasound is that there's no radiation. Other things that are good for ultrasound is that you're able to image small and superficial structures with this, and I'll show you cases after this. Another thing for ultrasound is that you are able to image vascular structures, and you can also see vascular flow on Doppler settings for ultrasound. And then finally, ultrasound allows you to look at structures on a real-time basis. And then cons for ultrasound. One of the issues with ultrasound is that it's limited by the patient's body habits and bowel gas. So a lot of times you'll notice that in a report will say this exam is limited because of bowel gas. It's because the bowel gas creates a lot of artifact that sometimes makes it hard to see what we're looking for. Another issue is that the ultrasound is often operator dependent. So unlike a CT where the tech basically puts the patient on the scanner and then does a couple sequences and scans the patient. But ultrasound technologist has to actually physically scan different parts of the patient's body. And as you can imagine, given the skill level and experience, sometimes findings are more difficult to see and image based on the ultrasound technologist's experience. Third is going to be focused images. So for an ultrasound, you are looking at exactly where you're targeting. So if you're looking at an ultrasound for a liver, you'll just see images of the liver. This is different than getting a CT of the abdomen pelvis, where even if you think the pathology is in the liver, you do get everything else that's also in that space. So if there are some unexpected findings, you'll see that on the CT regardless. However, an ultrasound, if you're not imaging in that part, you won't see it. So here are just some cases to showcase the different things you can see on ultrasound. So the first one we see is going to be an ultrasound of the gallbladder, and then you see this is going to be the gallbladder outlined here. You'll notice the gallbladder wall is very thickened. And then one thing that we do for ultrasound is going to be sonographic Murphy sign. So this is going to be, you have a clinical Murphy sign, and then we also have a sonographic Murphy sign, which is where the ultrasound tech takes the probe directly at the gallbladder, and then in the case if there's any pain specifically associated with that. So this outlines two things in terms of the usefulness of ultrasound, where you can see exactly how the patient's reacting to the ultrasound probe that you're not able to get on CT. This one is going to be a case of ovarian torsion, where you can see on the right ovary, it's compared to the left side. So this is going to be a normal ovary on this side, and you can see it's fairly small. It's got these orange areas which indicate flow on this Doppler image. So on the right side here, you do see the right ovary is expanded in size, and you don't see any flow here. So this is a classic case of ovarian torsion. And this highlights the usefulness of ultrasound in terms of looking for Doppler flow. Another case for ultrasound is looking for DVTs. So again, we do see Doppler flow as something you're looking for in ultrasound. Another thing is going to be compression. So in this case for DVT, what the ultrasound tech actually does is that they look at the vessel and then they push on it with the ultrasound probe. In a normal vein that it doesn't have thrombosis in it, it should collapse fairly easily. And then on this case, on the screen right here, you do see that there's echogenic material within the vein here, and then on compression, it is not collapsed. So that indicates there's thrombosis here. And another useful aspect of ultrasound is that you can image very superficial structures that you may not be able to see on CT. So this is going to be an abscess in the breast. So this is going to be the skin here, and this is going to be your subcutaneous fat. So this is a fairly superficial abscess. And you can see on ultrasound, you can see pretty detailed anatomy of how large the abscess is and how that relates to the subcutaneous tissue and skin, which is not something you'll get as well on CT. And then finally, two other cases I'll show that highlights the benefit of ultrasound having no radiation. So typically for pediatric patients, for appendicitis, ultrasound will be the first modality you do. And then here you do see, so this is going to be the appendix here as this tubular structure here. You do see increased Doppler flow. So all these red/orange areas are going to be increased Doppler flow. And you do see a thickened wall of the appendix. So this is a diagnostic ultrasound for acute appendicitis. And it's highlighting the benefits of ultrasound here. The next one I'll show is going to be for pregnancy, and this is going to be showing the fetal heart rate. So this highlights the ultrasound's ability to see very small structures, and also being able to image the heart rate in real-time imaging, and obviously there's no radiation associated with it. Next, we move on to MRI. So in terms of talking about pros and cons of MRI versus CT, so MRI, like ultrasound, also has no radiation associated with this. MRI uses a different type of contrast agent than CT. So if you have a patient with CT contrast allergy, this could be a good alternative for imaging. MRI also offers different types of dynamic imaging. So, for example, diffusion-weighted imaging is not something that you'll be able to do on CT. And then finally, MRI is better than ultra CT in terms of contrast resolution. And what this means is essentially looking for if you have a tissue with two types of tissue that are next to each other, whether or not you can tell that they're different types of tissue is what contrast resolution means. So here in this diagram, you'll see that on A, you can sort of make out there's black and there's a shade of gray here, but it's kind of hard. You may have to look a little bit harder. On B here, you can see that this is very distinct. So B in this case would have better contrast resolution. So for MRI, what this means is that you can see different types of tissue delineated better on MRI. The cons for MRI is that the scans typically take longer than CT. Usually for a CT, the patient is in the scanner for less than a minute, but for MRI, it can take up to 15 minutes to at least to an hour. Second thing is that MRI is not always available at institutions. Sometimes some institutions may not have MRI tech overnight. And then the third thing is that MRI has worse spatial resolution than CT. So what this means is that when you're delineating how sharp an image looks, so on this side, it's going to be something that's more sharper than something on the other side. So in this case, the CT would look like this, where MRI would like this, where it's more blurred. So next we'll talk about CT versus MRI specifically for stroke. So here's a head CT image here. And I'll just have everyone take a second to look at this and think about where the infarct is on this. So this case is fairly subtle. And then next we'll go to the MRI. So this is going to be the diffusion-weighted image of the same patient. And you can see that the infarct here in the left frontal lobe is much more apparent on MRI than on CT. And then, seeing this on MRI in retrospect, you can see that there's the decreased gray-white differentiation in the left frontal lobe here. But again, you can see this is much more subtle on CT than it is on MRI. And then also for stroke, there's also angiograms you can do on both CT and MRI. So one big difference between them is that for CT angiogram, you do need IV contrast. But for MRI, you don't need IV contrast. So for MRI, basically, you're essentially looking for the flow of blood within the vessels, which you can do without contrast. But as we talked about previously, the spatial resolution is better on CT. So in terms of looking for the degree of stenosis within vessels, CT is still superior. Next, we'll talk about CT and MRI for spine. So this is the case that really delineates the better contrast resolution for MRI. So on CT of the spine here, you do see that there's a disc protrusion here, but compared to the MRI, you do see it's more vague here, so it's a little bit harder to make out here. And then in terms of the spinal canal, it's very difficult to make out what's fluid and what's nerves within the spinal canal, especially if you compare that to the disc protrusion here. Everything looks fairly similar. But when you move to MRI, you can now see that the disc protrusion here is very well delineated against the bright. So this is going to be dark here, and then CSF is going to be bright on this image here. And then you can also see even the small nerve roots that are fairly difficult to see on CT. You do see them pretty well in the MRI. And then here you can see that the disc protrusion is pressing on this nerve here. So this really helps appreciate the benefits of MRI for spine imaging compared to CT. So now we're going back to the case of day here. So this is the image that we saw previously. And now I will just give you guys one more piece of clinical information. That the patient is on a neurosurgery service. And then we'll do the poll again and see if there's any changes in the way you guys think about this. Okay. Yeah, so I think this is a fairly subtle case. So I think, the lung findings are going to be what's catching everyone's eye first. But I think if you look in the spine, you do see that the vertebral bodies are offset here. And then on CT, again, you do see that this, much more obvious that there's a dislocation within the vertebral bodies. So I think this just really highlights the importance of having clinical information. So I think this is in the future for ordering exams. It'd be very helpful for you guys to provide clinical information. I think, even just a small detail like this patient's on a neurosurgery service can help really highlight this pathology. Okay, so we'll move on to the next part of the lecture. So this is something I call the hidden curriculum. It's basically concepts that are vital to the day-to-day patient care, but are not formally taught in textbooks. So this is just a quote from my internship program director. During orientation, would say the best intern on day one is the one who knows where the bathrooms are. So contacting radiology. So radiology at different institutions is typically divided into modalities based on body parts. And most institutions should have a chart like this where it tells you the phone numbers for different call rooms. So having something like this like on your phone would be very helpful in terms of like trying to call for findings during rounds instead of having to wait until after rounds to talk to radiology about findings. And then, so these are typically the divisions for different sections. One caveat I'll give here is that cardiac sometimes would be read by cardiology at some institutions instead of radiology. And the other thing is that some institutions will have an after hours imaging section, typically called acute care imaging. Next section, we'll talk about calling for an overread. So sometimes you'll have a patient coming in for another institution and they'll have imaging done at the previous institution. And then you'll call and to see if there's any differences in interpretation between your institution versus the previous report. So when you call, typically people are happy to give you a wet read or overread over the phone. Although if you look on the official document by the American College of Radiology, this type of informal communication is actually discouraged. You can request a formal overread in which a radiologist at your institution will generate a report on the same study done by the outside institution. So typically the way to do this is you would contact the imaging film library and then they will generate the section. And then this way the radiologist will see that there's a study to be dictated into. Two things to be aware of is that one, the patient may be billed again for the second read. And two is that institutions may have a different department for inpatient versus outpatient film libraries. So sometimes you may call into the wrong place if you're an inpatient, and you may call into the outpatient film libraries. Okay. Next section, we'll talk about radiology procedures. So I broke this down by different sections in terms of modality. So for neuro, typically you can do lumbar punctures for guidance for sampling CSF. And then you can also do myograms. So this is essentially a lumbar puncture, but now you're injecting contrast into the spinal canal. And this is usually for patients that need an MRI, but can't get an MRI for whatever reason, sometimes because of an implant or a pacemaker. And this helps delineate the CSF from the spinal cord and nerve roots. And then they can also do intrathecal chemotherapy, which is similar. You do a lumbar puncture first, and then you inject the chemotherapy. Chest section, there's some overlap between IR and chest at some institutions, and they can do both CT-guided biopsies and ablations for tumors. Body similar chests may overlap with IR at different institutions. So some of these procedures we've talked about already in terms of doing fluoroscopy. So this is an esophagram to evaluate the esophagus. If the patient has a gastrostomy tube and you want to check the position of the tube and check for if there's any leak, you can inject contrast into that. And also similar to chest, there's also CT or ultrasound-guided procedures to compete with that. For musculoskeletal radiology, different procedures we can do. One, you can inject into the joint. So for steroid injections, or if you're concerned about the septic joint, you can also put the needle into the joint and see if you can aspirate fluid and send that for analysis. Similarly, if you're concerned about bone lesions or if you're doing any kind of marrow biopsy, you can also do a CT-guided biopsy. Also for breast, there are different procedures to sample breast lesions. So you can do an ultrasound-guided biopsy versus a mammogram or stereotactic-guided biopsy. Next, we'll talk about consulting IR. So it's going to be similar to consulting any other service in a hospital. So the basic information for consulting are going to be the patient's MRN, a callback number, and the procedure that your team would like to have done for the patient. The next couple of things are good to have. So in terms of anticoagulation status, is this patient receiving heparin or any kind of anticoagulation? Do they have any pathologies that are making them more prone to bleeding? NPO status. And then this is going to go into anticoagulation again. And then clinical status. If is this patient walkie-talkie on the floor, or is there someone that's in the ICU? Any prior available imaging would be helpful. And then if they have any other procedures planned for a day. So for example, if they're going for hemodialysis for 4 hours today, that would be good to know in terms of planning for procedure. So in terms of anticoagulation parameters for procedures, typically IR likes to divide procedures into 3 categories in terms of bleeding risk. And you can kind of see on the left-hand side here, it's going to be procedures that are deemed less bleeding risk. So things like a paracentesis, a thyroid biopsy. These ones are typically low-risk procedures, and then on the opposite spectrum, you'll have more high-risk procedures. And then in terms of, for example, a renal biopsy. And the takeaway from this is basically INR and platelets. So for all procedures, you would want your platelets to be about 50,000. And then INR can vary from operator to operator, but typically you would want that to be below 1.5. For low-risk procedures, sometimes that could be below 2.0. And another thing that we typically get consulted on is when to turn off anticoagulation and when to resume it after a procedure. So this is just a helpful chart to see. Obviously you don't have to memorize everything, but essentially you could see that for heparin, you want to do that around 4 hours to 6 hours, depending on the procedure, and then that you can typically resume immediately after the procedure. And then for the new generation anticoagulation medications, that would take longer to treat than the last dose and resuming after the procedure. Next, I'll talk about radiology after hours. So this is something we talked about a little bit already in this lecture. So during the daytime, every subspecialty section is available and at night, typically only the on-call resident, sometimes an attending on-call as well, that is available. And as you can see, this creates kind of a conflict in terms of only the residents available overnight. So sometimes they may not be able to answer specific questions about subspecialty imaging. And then other things is going to be that typically the routine procedures is going to be done during the daytime, and there are many technologists available during the daytime. For overnight, typically only emergent procedures are done, and fewer technologists are going to be available during this time. This is a bit about the on-call radiology residents. So typically the way on-call is done in institutions broken down into 3 types. You have fully independent calls. So in this case, only the residents available overnight. So they'll prelim studies, and then the next day in the morning, the attending will overread the studies. So the prelim read you may receive is going to be no bowel obstruction. So this is going to address the acute question you're asking for the exam. And then the more non-acute findings are going to be deferred to the full report. So the next day you may have the same acute findings here, but then you may also get other non-acute findings added to the report here. So in this case, interval progression of metastatic cancer. The next type is going to be partial independent fault. So this is going to still have just the resident available on site, but they may be able to send the full exams to a third-party provider, teleradiology, if this is needed. And then finally, you have non-independent fault. So in this case, the resident and the attending are both available overnight. The resident still prelims the study, and then instead of the next morning, the attending will be able to overread the study within a few hours. So when the radiology resident or the attending is calling you with the critical finding, per regulations, I have to document the communication between them and the ordering provider. So this is, you'll hear this phrase a lot. They'll ask you for your name just so they can put in a report. And this happens both in terms of there's any acute or actionable findings. So for example, if there's a tension pneumothorax, or if there's an aortic dissection, these are going to require communication in the report. The second case is going to be when there's changes to what the prelim report says. So any critical changes will also require documentation as well. So next I'll talk a little bit about radiology rotations for medical students. So the different experiences typically depends on your goal for the rotation and what specialty you're going to. So I've broken it down into 3 categories. First one's going to be if you're going to a different specialty other than radiology. The second one's going to be if you're going to interventional radiology, and the third one's going to be diagnostic radiology. Regardless, so here are some resources that are good for learning radiology. The first one's going to be radiology assistance. This one is very useful in terms of there's a lot of good diagrams, and then also break down different findings on the image. Learning radiology is also another great tool on the internet. It's a little bit more basic, and it can give you just articles on different ways to read imaging. And then these are a couple other resources I've seen. So Felson's is a great book for early radiology residents. It's kind of like a multiple choice exam where you are reading along with the cases, and then you they'll ask you a question, and then you're able to think about what you see on the images, and then you'll see the answer on the next page. And then also there's different websites that can show imaging as well. So first type is going to be for students going into a different specialty. Typically, this is great for just kind of learning about workflow to your target specialty, and then learning about critical findings that we do see on exams like pneumothorax and pneumoperitoneum or acetylpulmonary embolus. A lot of times students also do these rotations after 3rd year. So, after a long, grueling 3rd year, radiology rotations is a nice way to kind of just enjoy the flexibility of the rotation. Usually I tend to like to dismiss students fairly early in the morning. So it's kind of like just like a nice relaxing rotation. The next case is going to be for students going into interventional radiology. And this is going to be similar to any other types of procedural audition rotation you're doing. And then usually people like to talk about the 3 A's for doing well on a rotation. So availability, always show up early and stay late. Affability, being able to get along with the people on the rotation is important, and not just the attendings and the residents, but also the people who handle day-to-day work of the specialty, especially the technologists and the nurses. And findability, this is where you can show that you've done reading and preparation for the rotation. So this is going to be similar to any kind of procedural surgical rotation you're doing. Every time you go into a case, you should know who the patient is and why you're doing the procedure. It's good to know at least the basic anatomy for the case. For example, if you're doing an endovascular case, kind of knowing where you're accessing and then how you're gonna get to that specific vessel that you're targeting. It's good to check up on patients that you've done procedures on. If they're admitted inpatient after your procedure, it's good to check up on to see how they're doing. And then you'll have plenty of consults on interventional radiology, and this is where a medical student can go and help out the team by seeing the patient, and then kind of discussing recommendations or questions with the consulting team. And then, as you progress through the rotation, you'll see different procedures multiple times. And then gradually you'll kind of know what each step of the procedure is. And this is great in terms of being able to anticipate what tools the operator needs for the next step and being able to assist them with that. So if you've done any interventional radiology rotation, you'll know that there's going to be a back table where the equipment is. And it typically looks like something like this. And then a couple of things I just want to highlight here. So one of them is going to be the sharps stand. So this is where you put all the needles and the any kind of sharp equipment here. And then two, you have this basin here. So typically it's going to be this blue colored container here. This is going to be filled with saline. And for interventional radiology procedures, especially vascular procedures, you'll use contrast to inject into the vessels to align the vessels. So in this case, a student's or a resident's job managing the back table is going to be make sure that the operator always has contrast available for the procedure. So if you think about the mixture between saline and contrast, the higher ratio of contrast of saline, the darker it is going to be on the image when you do the fluoroscopy. So that may make it easier to be seen, but that depends on what the area you're looking at. So typically attendings have a preferred ratio like I could do. People default to 50-50 or 60-40 on either side. So that's something good to check with the attending before you're doing this. Next thing is that you'll be standing near the back table and the techs and nurses will be handling equipment. So the attending may ask for a specific type of wire and then techs will hand it to you. This is where it's important to know not to contaminate the field. Next is going to be different types of wires. So you'll have hydrophilic wires and hydrophobic wires. Typically, the hydrophilic wire is going to be stored within the basin. So you'll kind of put them in their container and put them here, like in this picture here. And then finally, it's good to organize the sharps. Next one we'll talk about is going to be students going to diagnostic radiology. I think this is going to be the most tricky out of the three. The majority of the time when you're doing a diagnostic radiology rotation, you're sitting behind a resident when they dictate studies. There's not a lot of interactions between you and the actual study. And it's different in terms of clinical rotations where you're actively managing patients, and it's easier to kind of show that you're prepared by knowing more about your patients. So on diagnostic radiology rotations, the people there typically have no expectations for students in terms of knowledge. And the attendings and residents will rotate through the rotation on a day-to-day basis. So you may not get to work with the same people a lot during the length of your rotation. And then depending on how you're targeting locations, these may also be different. This may also be a double-edged sword. So for example, if you're doing multiple rotations in one specific state and I'm a program director in a different state, then I may see this as a negative in terms of potentially you coming to my program in a different state. But if you are very interested in going to that one state and I'm a program director in that state, then I would do see this as a favorable outcome for you. So tips for standing out. It's always good to look engaged and communicate if you need to step away. Typically rotations are going to be done in July through September, right during ERAS season. So if you have to answer an email or any kind of scheduling issues, feel free to let people know, and they're always very understanding about this. Another thing I like to tell students is that, one of the rotation is to have the people know you well at the program. So when you're applying, that people can put a face to a name. Typically when we're looking at students, most of the profiles in terms of staff and experiences are fairly similar. So when people are looking at your application and they can see your name and they can say, oh, well, this is so-and-so who did a rotation with us, that's very helpful. Consider doing a small research project. So during your rotation, if you see an interesting case, you can ask the attending resident if you guys can write that case up together. This is a great way to show initiative during your rotation. Typically, ARIS is a conference that has a submission deadline in late August. So if you're submitting to this conference, that kind of helps guarantee that you have something done before your ERAS submission. And then finally, if you're have any ties to the program, that's always good to mention. And other tips. So it's if there's an end of rotation presentation, that's somewhere it's good to show initiative and work hard on that presentation. If you're meeting with the program director during the rotation, it's also good to know the program well in terms of how many residents it has, different hospitals the program covers, things like that. And then finally, it's good to know that you're also evaluating your program. So you want to see the culture of the program, how the interactions between the attendings or residents are. And this is something we'll just go over very quickly. As a radiology resident, it's very different than clinical medicine. So for radiology residents, you have to do an internship here. So as a radiology resident, it's a lot less formal and less team structured than clinical medicine. It may feel like a third year of med school all over again. You go through different subspecialties, usually about 4 weeks on every service. And typically you draft reports and go over them with the attending, and you only work with the attending, which is different than working on a clinical team with different residents, fellows, and typically the first year resident is going to be the one to answer the phone calls. It may seem intimidating at first, but don't be afraid to ask senior residents or attendings any questions you may have. And if you don't know the answer to something, it's always good to just take down the MRN of the patient and a callback number for the team so you can call them back with the answers. And most programs will not have any call at the end of this year. For residency, moonlighting is a common aspect of residency where you can make more money. Most of the common moonlighting is going to be just sitting for contrast injection. These are, just in case the patient has a contrast reaction, which is fairly rare. Some programs can start as early as R1. These are some conferences that are good to go to for residents. And in terms of fellowship application, fellowship is very uncompetitive for radiology, so typically you can do research if you want, but it's really not required for fellowship applications. Yeah, thanks you guys for paying attention. Please let me know if you have any questions or comments, and here's my email if you guys have any questions.
Thank you so much, Dr. Liu, and thank you to all of the radiologists, attending residents that came and gave this boot camp today. Kelly just sent the feedback form for speakers. Please fill that out. It's really helpful for them to be able to guide these boot camps in the future and teach just more efficiently, more effectively, and it helps with their programs as well. So please fill that out. Anyone who fills it out will get the slides. This is the last boot camp in our series. So be on the lookout for next year's. We'll be uploading recordings of these to YouTube further down the line. And feel free to reach out to any of them or any of us with any questions. Thank you so much for being here on a Saturday.